Welcome to another EduMed video, and today we'll be doing the second part of our ventilation guide for beginners in intensive care. Today we'll be talking a little bit about ventilatory mechanics, and it's really important before you watch this video to go back to part 1. I'll do a quick review of the important key parts of the first video that we did, which was on the basics, but I please encourage you to go and watch that one first, because every single video from here on will be building on that first video's concepts and theories, and if you watch each of them sequentially, it'll make a lot more sense to you. We'll then think a little bit about normal breathing mechanics for the patient who's spontaneously breathing, and then about positive pressure ventilation. I think it's really important to understand the difference between normal ventilation and positive pressure ventilation, because the physiology is totally different, and therefore, when thinking about the pathophysiology of certain diseases, actually, for some, spontaneous breathing might be far better than positive pressure ventilation. But really, these are things that you need to be able to understand the basic concepts of in order to then move on to more advanced modes of ventilation. Before I move on any further, I'm going to put the next 2 slides up for a little while, just so I can reiterate the most important things. This slide has every intervention that you can possibly do with conventional ventilation that will improve a patient's saturations, their partial pressure of oxygen. This is it. These are the only tools that we have with conventional ventilation. One is to increase the fractional inspired concentration of oxygen. Then we can try and keep the alveolus open for as long as possible. So this is where the positive end expiratory pressure being raised may help to try and recruit up more alveoli. Sitting the patient up or thinking about the position which the patient is best put in to again try and reduce the amount of pressure on the lungs, either through the abdominal contents pushing on the diaphragm if the patient's lying flat, or the chest wall pushing down and the mediastinum pushing down if the patient's lying flat as well. We'll talk a little bit about clever ventilation in later videos, but there are modes of ventilation which may maximize alveolar recruitment. The really important thing to always think about, and I keep re-emphasizing this with every talk that I give, is always think about the alveolar blood flow. It's all well and good to have a fancy special ventilatory mode all set up, but if you aren't getting adequate perfusion of the lungs, and specifically the areas of lung that are aerated, there is no point. You need both perfusion and ventilation and a matching of both of those in order to get adequate gas exchange. And then the final thing, and actually the only thing that we can do as intensivists to try and improve oxygenation in the longer term and get people off the ventilator, is improving the alveolar blood interface. And that means suctioning all the pus and secretions that are sitting in the lungs, and also reducing the alveolar wall edema and also the capillary wall edema by driving patients negative in their net body fluid balance. Carbon dioxide is a lot more simple. Unlike the 4 things you can achieve with manipulating for oxygenation, for carbon dioxide removal, the only thing it depends upon is the minute ventilation, which means either increasing tidal volumes or increasing respiratory rates, or a combination of both, or optimizing cardiac output. As we go on to further talks, you'll start to see the pros and cons with increasing tidal volumes, increasing respiratory rates. I alluded to some of it in the first part, but there's a lot more to talk about. But really, you need to build on this information with further information which we'll be giving you to really understand the arguments for and against some of these management techniques. So let's think a little bit about normal respiration. So this is what you and I are doing right now as we're watching this video. When you're taking a deep breath in, so during inspiration, what you're doing is you're contracting your diaphragm so that it's pushing down, and you may or may not be using your intercostal muscles to bring your chest forward and therefore increasing the intrathoracic space. By increasing the intrathoracic space, what happens is that you create a negative pressure within the lungs. Therefore, relative to the lungs, the mouth and the nose has a relatively higher pressure. We know that gas will always move down a pressure gradient from an area of high pressure to low pressure. And as such, when you inspire, you take a deep breath in, you develop that negative intrathoracic pressure, you are going to suck air in through the mouth and nose and into the lungs. So this is how inspiration works. Now, the keen-minded amongst you may have already started thinking about something with the negative generation of pressure. We talked about the fact that ventilation and gas exchange is as much to do with gas coming into the lungs as it is blood coming into the pulmonary capillaries. And you can already start to imagine that if you generate a negative intrathoracic pressure, what you're going to be doing is sucking blood from the periphery, from the legs, from the abdomen, into the chest, into the right ventricle, and therefore you're going to improve cardiac output. So physiologically, over millions of years, we've developed a method of optimizing right-sided heart filling and therefore cardiac output and therefore cardiac perfusion with ventilation. So we're matching ventilation and perfusion as best as possible. And then during expiration, what you have is usually, if it's passive, a gentle recoil of the chest wall and a gentle recoil of the diaphragm as it relaxes, so it domes up, pushes up on the lung, and the chest wall pushes in on the lungs, therefore generating a higher pressure inside the lungs compared to at the level of the mouth. And therefore now gas is going to move down the pressure gradient in the opposite direction, from the relatively higher pressure in the lungs to the lower pressure at the level of the mouth and the nose. And that is how exhalation occurs. The clever thing that the body does is, if you're really breathless, you see people puffing away and you see them doing active expiration. This is where they're using their intercostal muscles and their abdominal muscles, their sternal muscles, to really push the chest wall down and therefore exhale as quickly as possible so they can take that next breath in. So you can see that expiration becomes active in patients who are spontaneously breathing if they're in respiratory distress. So now let's think a little bit about positive pressure ventilation. What we're doing here is, instead of the patient pushing the diaphragm down and pushing the rib cage and the sternum outwards using muscle contractions, now you've paralyzed the patient and you've put an endotracheal tube in, and so you need the ventilator to force air down into the lungs to push that diaphragm down and to push the chest wall up. Now, the only way you can do that is by generating a high pressure at the level of the ventilator, which then transmits down through the endotracheal tube and into the lungs. So now during inspiration, you are generating a positive pressure inside the lungs. And that positive pressure is what's causing the chest wall to rise and hopefully the diaphragm to push down. It is not active in any way, but now you've got a positive pressure. Remember what I said about blood flow. Automatically you can start to see that blood flow is not going to be as good, because now you've generated a high intrathoracic pressure. Not as much blood is going to be draining back into the lungs because the pressure gradient would have been reduced, because you've got a positive intrathoracic pressure as opposed to the negative intrathoracic pressure you would get during spontaneous breathing. Now, the next thing to think about is, if you think about passive inspiration and you have a listen with your stethoscope to the back of a patient, generally the bits of the lung that you hear the best are the bases, and that's because the majority of your breathing is done by a diaphragm contracting. Whereas if you listen to the chest of a patient who's intubated and ventilated, the bases are very poorly aerated, and much of the aeration that you get is the upper and middle lobes, which you see as the chest wall rising and falling with each ventilated given breath. This is very different to what you see when a patient is spontaneously breathing. And so you can start to think and see that the distribution of aeration of the lungs is different in positive pressure ventilation compared to normal spontaneous breathing. In positive pressure ventilation, much of the gas goes into the upper lobes and middle lobes, and because the diaphragm is pushing up with all of its abdominal contents, the lower lobes don't tend to get in as much aeration as the upper lobes. So if you've got ventilation and perfusion, generally speaking, if you're standing upright, much of your blood drains down into your bases, so all of the blood is there. But if all of the ventilation is happening at the upper lobes, which is what is happening in positive pressure ventilation, actually you're starting to develop a ventilation-perfusion mismatch. So that's why sometimes sitting patients who are positively pressure ventilated bolt upright, you might find that actually their oxygen levels start to drop a little bit, and that's because you're exacerbating that ventilation-perfusion mismatch. You're forcing the blood into the lower zones, into the bases, but all of the aeration is happening in the upper zones because that's got less resistance to the expansion of the lungs. So you can see immediately that the dynamics of ventilation are different between passive, normal, spontaneous breathing and positive pressure ventilation. Then we need to think about exhalation. That's the other really important part. Now, normally, in normal spontaneous breathing, expiration is passive. You just relax down and the diaphragm curls up and pushes the lower zones of the lungs up and the chest wall collapses down. However, if you think about the patient who has COPD or asthma, where there's narrowing of the bronchioles, it's hard to get air to come out of the lungs because they're so narrow. There, what you see patients doing is tripoding. They hold onto the sides of the bed. They're using all of their accessory muscles to squeeze that air out. So you see them really working hard during exhalation, which is why you hear that long wheeze. Now, if you have someone who is paralyzed, intubated, and with positive pressure ventilation, you lose all of that active expiration. The only way in which a patient can expire during positive pressure ventilation is by allowing that passive recoil of the chest wall and a little bit of the diaphragm that's moved down during the inspiration phase. In addition to this, the pressure differential between the inside of the lungs and the end of the ventilator is not as great, because now you've got, with most patients who are on the ventilator, you normally do it for hypoxia, you've got a little bit of positive end expiratory pressure. So the pressure gradient between the lungs and the endotracheal tube is actually less, because now you've got the PEEP there as well. So for all of these reasons, expiration becomes less efficient with positive pressure ventilation. Now, this is not something that's readily explained to people, and actually it's a really important thing to understand, because if you think about the patients that you intubate, the infective exacerbation of COPD, or the asthmatic patient where expiration is the problem, they gas trap, you can see their hyperinflated lungs. By paralyzing them, suddenly you have made a bad situation potentially even worse. Now, as we talk about more advanced methods of ventilation, we'll talk about ways in which you can potentially improve exhalation by putting things like heavy bags on the patient's chest so that the recoil is that much more, because you've got the pressure and the weight of the, say, for example, filter fluid bag sitting on the chest wall. But in terms of basics, you have to understand that actually these patients potentially could get worse with intubation. And the takeaway message that I want you to have is that positive pressure ventilation may make things worse. You must understand the dynamics of how ventilation works, both in spontaneous and in positive pressure ventilation. And only by understanding both will you then be able to give the best treatment to the patient. Again, these are decisions that are made by very senior clinicians like registrars or consultants, but it's always worth having that in the back of your mind. So in this video, what we've done is just very briefly gone over what we saw in the first video, and I really would recommend, if you haven't seen the first video in this series, to go back and watch that, because everything that we talk about from now on will build upon those concepts. We talked a little bit about the mechanics of normal breathing and how it differs from positive pressure ventilation, and what the consequences of that potentially could be for you looking after that patient on the intensive care, managing their oxygen and carbon dioxide levels. I hope you found this useful. Please leave any comments for any questions that you may have. I know this is quite a complicated area of intensive care, and I'll try and address them as we go along in future videos. Again, please like and subscribe, and if you hit the bell notification, you will see when the next video comes out. Thank you very much.